Can we please get our speakers back up onto the podium and we can take some quick questions and answers? Yes, David. Can somebody pass David the mic? Thank you.
So the questions about margins, it's because we are doing the 3D reconstruction on a ventilated lung. And that on a deflated lung, when we're doing the operation, even with the ICG staining, sometimes the intersegmental plane is difficult. And we ask the pathologist to assess the margins between the tumor and the intersegmental plane, but still on a deflated lung. So I think since we are not ready to modelize the deflated lung and to have the planification on the margins and the tumor on a deflated lung, we are still in a hazardous way, and we still ask for frozen sections. You're not convinced?
No, but the frozen section is important to absolutely identify whether you are R0. And I know we had a discussion last night about R0 being more than just a surgical margin because of the tumor, the circulating tumor cells, and whether that creates an issue of R0. But from in the operating room, R0 is R0 or it's not. I think there's, you can be more R2 than someone else, but if you're not R0, you're not R0. If I'm getting to the question that you're trying to ask, David.
But David, perhaps to be more honest, if we see the tumor and the intersegmental plane is very far away, we're not asking for a frozen section. That's it. But if we still that we are modelized the planification, we have done the segmentectomy very anatomically, and we feel that we are very near the tumor, we ask for a frozen section.
PDL1 is a very far from satisfactory test. The antibodies aren't that great. The repeatability between expert practitioners is not very high, and it's very patchy within a tumor, making the possibility of false negative in small biopsies quite high.
And the calculation of percentage expression?
It is terribly approximate. A machine could really help.
Hi, this is a question for Matt. Given that the positive results of Checkmate 816 were driven by PDL1 positivity and by stage 3, in which the majority of patients were stage 3, if you're going to take a pragmatic approach, you've got a patient in theatre with a 4.1 centimetre tumour, node negative, PDL1 0%, what are you going to suggest to them? Because a lot of MDTs up and down the country are giving them neoadjuvant chemo-IO.
I'd be very worried if I found myself in theatre in that situation. There isn't a guideline for it. There isn't a trial that's answered that question. So it can only come down to the patient having the opportunity to meet with people that understand those aspects of care and have the opportunity to hear all of that information and make a decision that is in line with their preferences. And that's incumbent upon us to go into those levels of detail. And it's hard. I think they're really difficult concepts to try and explain and bring over. But that's our job. And I think it's, as long as every patient gets the opportunity to meet with the treating specialists in an environment that supports good decision making, then that's the key.
Steve, with regards to the frozen section, you often find that the lymph node is positive, and very rarely lymph node come out in one piece with capsule intact. So there is some tumor left behind, whether microscopic or not. And what will you classify that as? And also at times you find that there is some lymph node at the resection margin and there was a tumor in that. So how do we classify these tumors?
It's an excellent question. I think lymph node resection, I always tell my patients when I'm taking lymph nodes out, it's like taking out sand. You honestly can't be certain of a complete resection when it comes to the lymph nodes. So the lymph node status becomes, if it's positive, and you've got a positive, an N1 or an M2 lymph node. And you have to take that into account for the adjuvant treatments. You know, the whole idea of counting your lymph nodes, I think, is when we heard this morning about whether robot versus open or versus VATS is better, and it came down to an argument of counting lymph nodes. I think that's tantamount to asking the person at McDonald's to tell you how many potatoes those French fries came from, because they come out in pieces. If it's positive, and that has an effect on your recommendations at adjuvant time. I think frozen section is important, though, especially when we're talking about margins and we're talking about smaller resections in the margins. We have a luxury, you know, at my place where everything is done by frozen section, and you can argue, well, are they accurate? When every case is evaluated at frozen section, that you build that muscle up. And those pathologists are very good at determining in toluidine blue whether or not they've got a frozen section that's positive or not. So I believe and you'll hear my talk on Tuesday about how frozen section is a big determinant of your operative outcomes in thoracic surgery. But I'll leave it to then. Yeah, the lymph node, if it's positive, and you've got to take that into account with your adjuvant care.
Thank you. Carol,
this is a variation on what David asked Agatha and Stephen. We got a T1A tumor, let's for argument's sake it's in the left upper lobe. You do a 3D planning, then you put the margins on the inner side, and it comes, well, it's just heading on, say it's a posterior segment tumor, and it's just going into a bit of the apical segment. What are you going to do? Are you going to do a segment and a wedge, or take 2 segments out, or are you going to do a lobectomy?
Well, I'll speak first, and I'll let Agnes give the right answer afterwards. For something like that, in the specific question you're asking, if it's close, I'm going to probably do an apical trisegmentectomy, like the A123. And if, you know, just the same thing as we talked about this earlier, Agnes and I, you know, if you had said that in the right upper lobe, you know, in the left, it's a lingular sparing upper lobectomy. In a right upper lobe, if you've got something that's bridging the 1 and 3, are you going to leave a 2? Agnes has good experience and will tell you about why she would do a 1 and 3. I might do a right upper lobectomy in those situations. I honestly believe in that slide where I said don't try and force a square peg into a round hole. But Agnes can tell you that all you have to do is expand the round hole to fit the square peg.
So first, I will not do a 3D reconstruction with inner side, but with visible patients, but just half of records. And then I will fit with the 3D reconstruction. So based on the location of the tumor, and if the anatomy is feasible, meaning not abnormal venous drainage and so on, even if it's a 1+3, I will do a 1+3 and try to spare the S2 segment, for example. Sometimes if the tumor is more central, yes, I will do a 3-segmentectomy of the left upper lobe, but I will base my operation on what the 3D reconstruction told me. And why? Why I will keep 1 segment? It's always the same questions, because you have no data on evidence on functional evaluation and so on. Because probably we are not using the good criteria to assess that we have no data on functional evaluation of the patients. I'm not sure that the FEV1 and DLCO are the best criteria to have the functional evaluation of the patients, because with all the segmentectomies we've done, the patients are better. We can offer a second operation, but at that time, we just do not know how to test that. Perhaps the test 6-minute walking test or some other exercise test to assess that they are in a better way for a second operation, for example. And also because the volume and the physiological of the lung is different. It means the distribution of the vessels and the distribution of the blood, if you keep one segment, could be the difference. And that there is some publication on that, on the changes in the physiological function of the lung if you keep just one segment, for example.
Hi. Sorry, Josh from Leeds as well. So I use 3D reconstructive software for all of the segments as well, and I find it very useful in terms of the anatomical vessels, bronchus, all that kind of stuff. My one concern is in terms of the definition of the segment, in terms of where the lesion lies. That depends on how the reconstruction has been made. So the softwares vary in how they define it. Some, they used to do it on bronchial, so bronchopulmonary anatomy, and the majority of them changed towards doing arterial supply, and not necessarily even looking at the intersegmental vein as the definition.
That's why I say I use visible patient, because we've done a study where we compare intersegmental plane and simulation of the segmentectomy based on the bronchi and based on the arterial blood supply, and it was similar with the visible patients model. So we are using it based on bronchi. We simulate that we cut these bronchus, it take a whole volume, and we know that it's similar to the arterial supply. So when I will use the ICG, I will have the same vision of what I've done with the planifications.
So if the others use either arterial or bronchus, in theory, that's okay too then?
I just do not know how the concordance on the others models, because it's based on mathematical way to do that. So you just have to assess if it's similar. So you only have to test materialize, inner site, and so on.
Yeah.
Because we compare arterial, bronchus, and what we have done with the ICG. It was the three things together.
Thank you. Just one last question from myself. The resectability, Matt, you mentioned the surgeons come together. I find there's a bit of a debate around resectability, especially in the context of N2 disease. You know, are we being a little bit more aggressive about taking on cases that we now consider resectable because we can take it out, but from an oncological perspective, is it the right thing to do? Do you think there's been a shift around surgical mentality about what is and what isn't resectable in the context of offering chemo-IO versus radical chemoradiation?
Again, I'm probably the wrong person to answer, to be honest. I think we've tried to very much not let any mission creep happen from any suggestion of neoadjuvant downstaging or creating resectability, and stay well away from that. I think probably our practice in GM was quite broad regarding to N2 anyway. I think we moved away from single station, multi-station definitions quite a long time ago. So I don't necessarily think it's made us any more. I don't know if Alicia might want to comment, but.
Because a definition of resectability is about whether you can take something out with clear margins. So we never thought that, and we have never changed it as a result of neoadjuvant protocols. And what Matt was alluding to, our surgical friend meeting is primarily based on assessing that parameter, resectability, by a group of 3 surgeons, so that when we then come to the MDT, the individual might be not as experienced or as bold as many others. So, you know, he's protected by some kind of MDT approach, or sort of not a single individual approach to what we define resectable. Obviously, at that time, we also, you know, at the time of the surgical meeting, we take into consideration the other parameters that Matt has talked to, for example, PD-L1 expression, for example, lymph node involvement, I remember Tim talking about, were you talking about T3 and 0, whether we remove it or we give neoadjuvant? Is that what you were asking before to Matt? And, you know, we would, and you have seen, so half of our resected patients have had surgeries up front, despite being eligible for neoadjuvant treatment, because we look at PD-L1 expression, we look at nodal involvement as important parameters to decide whether we think an operation up front or after chemotherapy is the way forward. I don't know whether that answers. But yes, we do take multi-station and two out, as long as it's not bulky and as long as we think we can remove it completely.
So you've always been upsetting your radiation colleagues. Okay, great, thank you. Any more questions? Yeah. Okay, great, thank you.
So it's a question for John. I love your topics. We try to work on that, so it's a question and a comment. I think there's also some images that we forget to analyze, because you came with the histopathology, saying that the pathologist's view was quite blind. And I think we are not using also the PET CT and the CT before the operation, in which there is a lot of features and radiomics and so on. Do you think you can bring that together to your models and to add it to get a better value to predict the outcomes? Just not use the digital pathology, but also bring and add the ER on the CT and PET CT?
I mean, absolutely. And that has to be the future, I think, to try to limit the possible truths using all the information that's available in CT. And we know that there's a lot of subtle feature information available within tumors in CT that does that. And then to further limit the possible scenarios with what you can discern from a small biopsy. Again, probably using machine intelligence to extract every last gram of information is going to be the way forward.
Okay, thank you very much to all four speakers for excellent talks.